From the United Nations Population Fund, Geeta Sethi.
I am indeed honored to welcome you to the closing session of this amazing conference. It's been 3 spectacular days, a medley of memorable moments, rapt attention during presentations, the buzz around condomizing, hugs and kisses as old friends reconnected, serious questions around new technologies, and pride in the assembled flags. This conference has been truly significant. It provided a space for us, brothers and sisters in the HIV response, to come together to celebrate progress and strategize around addressing challenges. We have heard of scientific advances in treatment and prevention and socio-cultural barriers to making the most of the promise of the present. It is time now to reflect on what we have heard and on how we will apply this knowledge to the HIV response in our own settings. So many persons, particularly most at-risk young people, as well as highly respected scientists and leaders, have spoken openly about their experiences and what we need if all persons are to enjoy a life of equality and health. Their voices remind us that countries of the region will need to take some well-thought-through and possibly unpopular decisions in order to eliminate stigma and discrimination, protect the rights of vulnerable groups, and make universal access to HIV prevention, treatment, and care a reality. This conference occurred at a critical juncture when the prevailing economic conditions threatened to limit available funds, and when many Caribbean countries are preparing for general elections. These 2 factors amplify the need for strategic and evidence-informed approaches based on emerging technologies and on knowing our epidemics to guide us to target resources to the core of the issues and ensure maximum efficiency. We want vigilance on the part of communities to ensure that existing governments and candidates vying for leadership positions honor the commitments made in various international declarations and instruments through ownership of national programs and investments. It also enjoins each of us to do our personal best to ensure that there are 0 new infections, 0 AIDS-related deaths, and 0 stigma and discrimination, that indeed we soon have an AIDS-free generation. The evidence indicates that youth aged 15 to 24 account for more than 40% of all new infections. In addition, although HIV prevalence among the adult population in this region is around 1%, among the most at-risk populations in some countries, it is as high as 30%. The available data tells us where the gaps and areas of vulnerability exist. We also have the technology and the will to create a roadmap for action. Let us not circumvent the evidence, but be bold and brave to revolutionize prevention. Our next presenter will bring us some insights into achieving the goal of universal access through an exploration of the topic toward a stigma-free HIV response, ensuring equity in evidence-based services in the Caribbean. It is my pleasure to introduce Dr. Farley Cleghorn, the Senior Vice President and Chief Technical Officer of the Futures Group. Throughout his career of more than 20 years, Dr. Cleghorn has been a leader in the field of combination programs for HIV prevention. He recently initiated the Sexual HIV Prevention Program of South Africa, the largest prevention program funded by the US President's Emergency Plan for AIDS Relief, also known as PEPFAR. He has made many original contributions to the field of human retrovirology and previously served as Deputy Director of the Institute of Human Virology at the University of Maryland School of Medicine. Before his current appointment, Dr. Cleghorn directed the Futures Group Center for Health Solutions. Dr. Farley Cleghorn.
Good morning, and thank you for giving me the honor to do this job today. It's great to be here among old friends. In 1986, I started a clinic in Port of Spain for people living with what we called HTLV-3 in those days, before it became HIV. And that clinic was funded with NIH funds. That clinic is still running today, and it's funded by the government. And the first thing I'd like to say, and of course I would like to also observe that I thank the organizers and the sponsors, particularly the National Institutes of Health, Perry Gomez in the Bahamas, for organizing a meeting that I think is a rejuvenation for many of us. We've come to this meeting after approximately 6 years since the last one, and I think we're seeing a lot of progress. We are seeing, for example, that over 50% of those in need of treatment in the region are receiving or accessing treatment. We are seeing close to what is the elimination of congenital HIV and syphilis infection in many of the countries of the region. And in fact, we think that overall prevalence is going in the right direction. We're making progress in reducing overall prevalence in the region. However, we still have a lot of work to do. And for those of us who have the ability to look at the entire region, we can see that prevention is the area where we need to do some rejuvenation. We know that over 20,000 new infections are occurring in the region still every year. And this has been mentioned by many of the presenters over the last 4 days. How do we, in fact, get to the zero new infections that's one of the themes of this meeting? And today, I want to explore with you one of the reasons we think that we aren't getting the kind of progress we could get in prevention, and that is to explore the issue of stigma and discrimination and its role in keeping new infections at the level that we're seeing them today. Stigma and discrimination, as you all know, and this is a term that is used quite often. We tend to use it together, like monitoring and evaluation, and we sometimes don't stop to examine what in fact is part of this term, stigma and discrimination. On this slide, you see a poster from the Barbados AIDS program, which is meant to showcase that compassion for patients living with HIV, in fact, doesn't hurt anyone. It helps. But we want to go beyond compassion to empathy and to acceptance. And that is why we focus on stigma and discrimination as both a tool that we can use in order to extend the quality and the impact of the programs we are implementing today and the resources we are expending today. My talk is going to focus on just 3 things: giving us some vocabulary around stigma and discrimination, and understanding what we can do in the healthcare setting, because so many of us in this room are from the healthcare sector, what we can do without a huge investment, what we can do to make the healthcare setting an oasis from stigma and discrimination, and to talk about some next steps that we can embark on individually and collectively in order to reduce the impact of stigma and discrimination in the Caribbean. So, as I said, we need a little vocabulary here. Stigma, as you all know, is a social process. It is contextual, that is, it arises from social, cultural, political, and economic forces. And essentially what it does, it separates people into groups. It creates the me and the you, or the me and the other. And it leads to some kind of devaluation that creates superiority in one group and inferiority in the other. And this can lead to social exclusion. It can actually lead to much more than social exclusion. These same forces operate, for example, when there's genocide in parts of the world that you all know so well, like in parts of Africa and Asia. And But the stigma we are talking about today is the stigma that disqualifies certain parts of the population from full social acceptance, and therefore from the full expectation that they can participate in the benefits of society, in the advances in medicine, in the advances in policy and in practice that everyone should feel equally part of. Discrimination, on the other hand, is usually the result of stigma, and it is defined here as an unfair and unjust action towards an individual or group based on real or perceived attributes. And those attributes include, of course, HIV and AIDS, and many other medical conditions, not just HIV and AIDS, but it covers a wide range of factors like socioeconomic status, gender, race, sexual orientation, place of origin. And in this region, which is, of course, full of migrants from one place to another, place of origin is a significant source of stigma that we have to acknowledge. Stigma, of course, for it to create harm, does so in a number of ways. Enacted stigma is the discrimination that is experienced, that is dealt from one person or one group to another person or another group. But there are other types of stigma. In fact, we found that anticipated stigma, that is the fear of being stigmatized, is a very potent force in determining how members of certain groups access services for HIV and AIDS. Very importantly, there is internalized stigma or self-stigma, and that is where people devalue themselves because of the stigma that they experience from others, but because of the collective force of what they believe about themselves because of certain characteristics. There's also secondary stigma. If I walk around with my gay friends, I could be stigmatized if I walk downtown in Kingston, Jamaica, perhaps. And there's also compound stigma, which is layered. That is, for example, if I, as a gay man, have HIV/AIDS, then I not only am stigmatized because I'm gay, but I'm stigmatized because I have HIV or I have AIDS. These are the important types of stigma that we all have to acknowledge play very important roles in the work that you are all collectively trying to do in this region, which is to mitigate the impact of HIV and AIDS. Why is stigma and discrimination important for HIV and AIDS? Well, as you can see from this slide, there are many services, all of which you are trying to implement today at scale. That is, you want to cover the needs for the problem, you want to deliver quality, and you want to do it at the intensity that is appropriate to the problem. Both prevention and treatment care and support are arenas where stigma actually discounts your investment that you're making today. If you think in economic terms, stigma and its resulting discrimination discounts the investment that you're making in all of these areas, prevention, treatment, and in the health systems that will make this response sustainable. The picture on the left of this slide is actually a book that was written by Jamaica Kincaid about 10 years ago. It's called My Brother, and it's about her brother going through his illness and eventual death from AIDS. And it's also about her discovery about the forces at play in her own family, where she has a gay brother who becomes HIV infected, becomes sick, dies, and she goes through this process of self-discovery that actually helps us to articulate some of the issues that are central to stigma and discrimination for the individual, for the family, and for society. I recommend that you all read this book. It's one of the few novelistic biographical interpretations of HIV/AIDS in the Caribbean that's explicit. More recently, we've had an autobiographical work from Jamaica from Rosemary Stone, and we've had a couple of other plays and movies that deal with HIV/AIDS. But in general, we don't have a lot of literary interpretations of the disease, and this may in fact reflect the issue we're talking about, which are the distancing mechanisms that societies go through in order to not discuss something that may be sensitive or disturbing. Stigma also enables fear and discrimination and perhaps violence. We live in a region where there are gender inequities. Women and girls suffer from these gender inequities much more so than men. And the picture on the right shows two young girls selling donuts by the side of the road in Jamaica. And they're alone, and they're making a living to help their families. But this actually puts them at increased risk of sexual violence and other types of violence. And this, of course, applies not only to women and girls, it applies to sexual minorities, such as gay men. It applies to transgender individuals, where simply being in the social space may give rise to discrimination and violence because of immutable characteristics. I threw this in here because this is an HIV/AIDS meeting, and I've looked through the program and I've gone to a lot of sessions, and I didn't think that we had we didn't have enough of an explicit discussion of the sexual underpinnings of HIV transmission in the region. This is not necessarily a criticism, but it is an observation that HIV is a sexually transmitted disease, and one of the important ways in which we can deal with transmission is to have open and explicit discussions of sexuality, particularly for young people between the ages of 15 and 24, and even before they enter their sexual life. Young people they deserve to have unbiased information about sexuality and about healthy sexuality that is unencumbered by some of the biased opinions that we sometimes have. And as I said, I threw this slide in here because this young Trinidadian filmmaker, Jamel Patrick, actually put a sign up that said vagina, stood on a highway in Port of Spain and filmed the responses of people to that sign. And it's a very eye-opening film, but it does talk to us about the everyday cultural references to women's genitalia, in fact, may not be constructive, they may be comedic, but again, it's a distancing mechanism to allow people to not address direct drivers of behavior. We can't talk about stigma and discrimination without talking about the legal environment in the Caribbean. And we have spent a lot of time and effort dissecting this out. Obviously, you can see from the slide that we have a long way to go, that there's still criminalization of sexual minorities, particularly homosexuality. There's lack of protection for people living with HIV and HIV-related conditions. And we even have laws that criminalize HIV transmission in the region. They're not common, but they do exist. And conferences like these give us the opportunity to examine ourselves dispassionately and to see that our environment still provides some of the emphasis. This would be a structural impediment to the removal of stigma and discrimination as an issue in the HIV/AIDS response. There's a lot of work to do still on this, and there are many agencies, including UNAIDS, that's taking a lead role in doing so. I just wanted to reiterate and to remind you that these kinds of structural, in this case legal impediments, they actually promote the epidemic. Homophobia promotes HIV transmission, and it does so by social exclusion and by diminishing the impact of programs that can lead to the reduction of transmission of HIV. This slide shows very clearly that in many territories of the Caribbean, gay men are still at vastly increased risk of HIV transmission, and that can be directly linked to the structural issues of homophobia and the legal environment and the inability to take their place fully within a society. This is something that we all have to work on together if we want to say that we have an effective HIV/AIDS response. I was asked to put in a couple of personal notes into this talk. As I said, it's great to be among old friends. I've known many of you for over 30 years. You all know I'm gay. This year, my partner and I had the great opportunity to get married after 24 years, which we did in DC. Thank you. But what I wanted to say is that when we talk about stigma and discrimination, not everyone experiences it. And throughout the Caribbean region, where people are kind-hearted and very warm, I can say that I did not experience stigma and discrimination. And this is something that we need to harness in the region, because everyone should have that expectation. And throughout my life in the region, going to UE, going to medical school, setting up that clinic in Port of Spain, doing excellent work with NIH funding for many years, no one ever said to me, "You can't do something. Just do whatever you need to do." And this is the kind of attitude that we can extend to an entire generation of young people who are making their way in the world. I said that we would focus specifically on the healthcare setting because so many of us are healthcare workers, and HIV exists in the healthcare space for many patients, even though it exists broadly in the social space. And there is so much that we can do in the healthcare setting that can mitigate the impact of stigma and discrimination. And how can we do this? The healthcare setting should be and must be a safe and competent space for people living with or at high risk of HIV. It must be that, and it can be that, and it can be that relatively easily. This slide simply intends to show that there are many reasons why people don't access health services or don't think that they're going to get the kind of service that they should expect. And we can change that through some very simple interventions. And what are those interventions? First of all, we have to understand how it is that healthcare workers can influence their patients and their patients' acceptance of services and uptake of services and the impact of services. And on this slide, which of course you will all have very shortly because we'll share it with you, we've just attempted to categorize into various groups, things such as neglect, differential treatment, lack of consent, denied care, verbal stigma, the use of words. And when we say the healthcare setting, by the way, we mean everyone in the healthcare setting, from the guard to the lab tech to the clerk to the nurse and to the doctor. All of them have an obligation to reduce their contribution to stigma and discrimination for patients living with HIV or STIs or any other disease that is stigmatized. And the way we can do this is to understand what stigma-free healthcare services look like. They should have guidance, of course, that outlines what stigma and discrimination-free services are, what they look like, how they are described. Everyone should have some kind of training. And as we said, the training does not have to be elaborate. This is essentially awareness raising and guidance. We have to monitor client satisfaction, specifically with regard to stigma and discrimination, and we have to include the populations being served by the healthcare setting in the evaluation and the monitoring of stigma-free healthcare services. Now again, we do need to have vocabulary. We need to understand what we're talking about. And there are many immediately actionable causes of stigma and resulting discrimination in the healthcare setting. The first is lack of awareness. And of course, we can get around that by appropriate training and by modeling our own individual behavior. The second is the fear of casual contact, or what we refer to sometimes as exaggerated beliefs about HIV transmission and about the people who get HIV. And finally, it's the linking of improper societal behavior with HIV that may sometimes lead to both individual, environmental, and structural stigma and discrimination. We are saying here today that we can eliminate all three of these, individual, environmental, and even structural, although it takes longer. But in the healthcare setting, we can certainly do it. Here's how they would do it. Or rather, here is the philosophy behind it. Healthcare professionals can and must contribute to the change in the environment to make it welcoming and competent. HIV services are a partnership between the healthcare service and the people who need the service. And sometimes, of course, the healthcare worker can become the patient and vice versa. We have to acknowledge that. We can teach and guide our leaders in our community about the harms of stigma and resulting discrimination, and we can all individually model our own behavior so that we are not contributing to stigma and discrimination. And I want to drive home this point, which is that we've talked a lot over the last 4 days about the amount of investment that we've put into the HIV/AIDS response in the Caribbean region. But essentially, if we don't deal with the structural and environmental issues of stigma and discrimination in the AIDS response, you discount your investment by up to 30%. Now, that number varies, and it varies in different parts of the world, but essentially, you will get more for your money. So there's an economic argument, there's a humanistic argument, and there is the healthcare Hippocratic argument to eliminate stigma and discrimination in the healthcare setting. What are some of the next steps? Obviously, we have to recommit ourselves, both collectively and individually. And while some people may think, here we go again, another framework, essentially, as I said, we need to have some structure, we need to have a vocabulary, and we need to measure ourselves, evaluate ourselves on how we're doing. So we have to have some data. And we need to invest in stigma through training, through interventions, and through, of course, investment in dollars in order to eliminate stigma and discrimination. At the risk of sounding repetitive, we do have to contribute to the knowledge base and determine how we're doing by collecting information and examining trends in services and availability of treatment and, of course, stigma reduction. We can measure these impacts very easily. This is not additional data collection that you have to do. This is simply adding a couple of variables and a couple of methods to the information you're already collecting. So we can build an evidence base to evaluate ourselves over time. Structurally, ministries of health have a big responsibility because so many of our services for HIV/AIDS fall within ministries of health and their purview. I urge ministries of health in the region to partner with regional agencies and international agencies to understand how they can monitor and evaluate the impact of stigma and discrimination in the healthcare services that they are delivering for HIV-infected individuals and for those at high risk of HIV. What will you do? All of us can do something. And essentially, what you can do is to be a committed individual. And over 1,000 of you committed in this meeting at the Stigma and Discrimination booth to be an agent of change against stigma and discrimination. And you all put your handprints and little notes onto this banner. And it's very impressive that so many of you did, because individually is where the action is. Each of us can today commit to not contributing to the furtherance of stigma against HIV-infected individuals and against people at risk for HIV. That's a very impressive banner. Give yourselves a round of applause. And if your handprint is not on this banner, you still have a chance to do so. We can wrap it around the room. Finally, while you're looking at that, I want to say that there is also a stigma network that we have started. A number of organizations have started. It's an international network that we can all become part of, both as organizations and as individuals. And it is a forum to share best practices on how to reduce the impact of stigma and discrimination in HIV and AIDS and in healthcare services in general. And then finally, I would like to thank the organizers again. So many organizations need to be thanked, but I want to point out a number of them. NIH, of course, the organizing committee, USAID for funding some of the stigma and discrimination work in the region under the Health Policy Project. I also would like to point out that there's also a DFID-funded Regional Stigma and Discrimination Unit, and this is all one set of work, so we're going to be collaborating on this. And of course, PEPFAR and the US government, PANCAP, which has been a partner in this work and is going to continue to drive this work through its regional coordinating mechanisms. Thank you very much.
Ladies